Section 1. Stroke Risk and Pathophysiology. Let's get right into it.
Think about this. Atherosclerotic occlusive disease of the extracranial carotid artery is a massive driver of morbidity. We're talking nearly 800,000 new strokes happening every single year in the US. That's a staggering number, and the estimated total cost is over $40 billion. So the stakes could literally not be higher. But here's the truly terrifying part. There's a 30% initial mortality rate, and for the folks who do survive, about 60% are left with long-term disability.
So what's actually causing these strokes? It really comes down to three core mechanisms: atheroembolization, thrombotic occlusion of a severe stenosis, and, much less commonly, global cerebral hyperperfusion. Now, the major hotspot for atherosclerotic plaque to form is the carotid bulb, primarily because of the dynamic flow changes and wall stress right there. But what you absolutely have to watch out for is the vulnerable plaque. This is an unstable lesion that is just waiting to embolize. If you're looking at a carotid duplex ultrasound, a vulnerable plaque is going to look distinctly hypoechoic, it'll be heterogeneous, and it'll have an increased plaque area. If you spot those exact features, you know that patient is facing a 3- to 4-fold increased risk of a stroke.
Moving on to Section 2. Clinical Presentation and Signs and Symptoms.
Okay, definitions matter here. You must strictly define a transient ischemic attack, a TIA, as a transient hemispheric neurologic deficit that resolves entirely within 24 hours. Got that? Less than 24 hours. Now, if these attacks start happening in rapid succession, with shorter and shorter intervals between them, we call those crescendo TIAs, and those demand emergent evaluation. A classic, incredibly testable presentation you'll see is amaurosis fugax. Patients will literally describe this as a window shade coming down over one eye. It happens because atheroemboli get lodged right in the ophthalmic artery, and if you do a fundoscopic exam, you'll actually see the classic Holland horse plaques.
This comparison perfectly highlights the difference in acuity. Like we just said, a TIA resolves quickly. But if that neurologic deficit sticks around beyond 24 hours, well, it is officially considered a stroke. Now look at the right side, a stroke in evolution. This is a scary scenario where a deficit fluctuates and gradually worsens over hours or days right while you are observing the patient. Just like crescendo TIAs, a stroke in evolution requires absolute immediate attention. Those symptoms aren't just going to magically return to baseline on their own.
All right, Section 3, Diagnostic Imaging for Evaluating Stenosis.
Take a look at the strict diagnostic hierarchy here. Your initial go-to screening test? That's the color flow duplex ultrasound. And honestly, in an accredited lab, it is so reliable that you can actually proceed straight to surgery based on this scan alone up to 95% of the time. Now, CTA and MRA are fantastic supplementary tools. They give you great 3D detail, though you do have to keep the contrast-induced nephropathy risk in mind with CTA. But the conventional catheter angiography, that remains the absolute gold standard. Because it's an invasive procedure and carries a tiny, less than 1% risk of actually causing a stroke itself, we generally reserve it for patients who have conflicting non-invasive studies or those who are already slated for carotid stenting.
Section 4, Best Medical Therapy and Risk Factor Modification.
Let's distill this high-yield table. Medical therapy is all about intense risk factor modification. Antiplatelet therapy is your absolute cornerstone. We're talking aspirin at 81 to 325 milligrams a day, which slashes the risk of major vascular events by 22%. But you also have to hit some very rigid targets. You want to drop that systolic blood pressure to a strict 120/80. Keep that hemoglobin A1C below 7, and you've got to use statins to cut LDL by 50%, specifically targeting an LDL under 70 milligrams per deciliter. Oh, and total smoking abstinence, that is completely mandatory. No exceptions.
Next up, Section 5, Endarterectomy and Surgical Management.
Now, surgical indications aren't just based on what the surgeon feels like doing that day. They are rigidly dictated by massive randomized controlled trials that compared surgery directly to best medical therapy. The NASCET trial proved that carotid endarterectomy, or CEA, is highly beneficial for symptomatic patients with greater than 70% stenosis, and it also helps those in the 50 to 69% range. Then you have the ACAS trial, which established that asymptomatic patients with greater than 60% stenosis also benefit from the surgery. But here is the big catch. The surgeon absolutely must achieve meticulous perioperative adverse event rates. We're talking below 3% for asymptomatic patients and below 6% for symptomatic ones.
So if you want to crush this on exam day, you have to memorize these exact cutoffs. For an asymptomatic patient, you operate when there is greater than 60% stenosis. For a symptomatic patient, you have to be much more aggressive. You operate at greater than 50% stenosis, or if they have an ulcerated lesion and continue having symptoms even while on aspirin therapy.
The surgical technique itself demands an absolutely strict sequence. Why? To prevent devastating intracranial embolization. After you make the incision and push an IV bolus of 5,000 units of heparin, the clamping order is absolutely vital. Remember this: you clamp the internal, then the common, then the external carotid arteries. Next, you remove the plaque in the correct plane, tack down any loose intimal flaps, and close it up with a patch. Finally, the unclamping order reverses the flow to push any potential stray debris safely away from the brain. So you unclamp the external first, then the common, and finally the internal carotid artery.
Postoperatively, your job is far from over. You have to aggressively monitor for 3 major complications. First up, myocardial infarction. This is actually the most common cause of early post-op death, which makes sense when you realize 25% of these patients have severe coronary disease. Second, cranial nerve injuries happen in about 5 to 10% of cases, and the hypoglossal nerve is the most commonly injured. Finally, you have to watch like a hawk for cerebral hyperperfusion syndrome. This usually shows up as a severe headache a few days post-op, and it carries a terrifying risk of intracranial hemorrhage. You have to keep their systemic blood pressure strictly controlled. Moving to our final section, Section 6, carotid stenting and the endovascular approach. Because an open CAA is so safe and well-tolerated, stenting is strictly reserved for high-risk patients. What do we mean by high risk? Think severe cardiac disease, like an ejection fraction below 30% or a recent MI. It also includes patients with a hostile neck, so maybe they've had prior ipsilateral neck surgery or prior neck radiation. It also includes folks with contralateral vocal cord paralysis. In those patients, an open surgical nerve injury would be absolutely devastating to their airway.
This endovascular technique is all about meticulous wire skills. You usually start with retrograde femoral access and pass the wire across the stenosis. But the critical do not miss step is deploying an embolic protection device, which is usually a filter, up in the distal internal carotid artery before you ever touch that plaque. Seriously, only after that filter is open and ready to catch debris do you go ahead with predilation and deploy the self-expanding stent across the bifurcation. Now, stenting comes with its own unique set of complications. Embolic stroke is the most common one, which is exactly why that distal protection filter is non-negotiable. Plus, you really have to anticipate extreme hemodynamic instability. When you inflate a balloon to stretch out that carotid bulb, you are directly stimulating the baroreceptors. That causes profound bradycardia and hypotension. Because of this, you absolutely must pre-treat the patient with atropine or glycopyrrolate before you even start dilating. To close out this rapid clinical review explainer, let's test your active recall with a classic exam question straight from the text. Which major cranial nerve are you most likely to injure during an open-end arterectomy? The answer, as we just covered, is B, the hypoglossal nerve. Knowing things like the rigid criteria from the NASCET and ACAS trials, memorizing your anatomical clamping order, and recognizing exactly when to switch from open surgery to stenting will serve you incredibly well both in practice and on your exams. But it does leave us with a fascinating question to ponder. As endovascular technologies, like flow reversal systems, continue to evolve and drop complication rates in high-risk patients, will the classic open carotid endarterectomy eventually become a procedure of the past? It's a huge debate right now, completely redefining vascular surgery. Until we know the answer, keep reviewing those facts, and I'll see you in the next explainer.